Okay, so isn't that fill you with great enthusiasm about the great work that people are doing, and actually the feedback that we're starting to get is really positive. So for the second time this morning, I shall introduce the Cabinet Secretary. Very pleased to have her this morning, so thank you, Cabinet Secretary.
Thank you very much, Jane, and it is an absolute pleasure to be with you this morning. What a fantastic video, even looking at it sideways. I must watch it properly. It looked great, and it reflected the little that I've been able to see myself so far in this role when I've visited some of the places where work has already begun on Best Start. So I am delighted to be here to mark 2 years since the Best Start, a 5-year forward plan for maternity and neonatal care in Scotland, was published, and with you to celebrate the changes that are already happening in Scotland as a result. So Best Start was published in January 2017. It's now 2 years old. You could say that it is now a toddler. We've passed the newborn stage of trying to understand what this thing is, how it works, and we've now found our feet and can explore the world. And just like a toddler who is fascinated by the big new world they're only just starting to explore, that new world is, for many of us, uncharted territory as yet and can be a bit scary. At this point, I now promise you that that analogy is over. It did actually carry on for a wee while, but honestly, you don't deserve that. You don't deserve it. The Best Start represents a fundamental change in the way we deliver our services. And as we all know, for many, change is exciting and invigorating, but it is not always easy. And for many of us too, it is neither exciting nor invigorating and can be a bit scary, as indeed somebody said in that video. But the changes we are making with the Best Start are the right changes, and they're for the right reasons. With the right communications, leadership and support, we want you to help shape what the new world of maternity and neonatal care looks like for you and for the women and the babies that you care for. Last year, 5 early adopter boards were identified. They reflect a range of different demographics, populations and geographical areas. They were given the task of leading the way across Scotland on implementing a range of recommendations on continuity of carer and local delivery of care. Our 5 early adopter boards are all well advanced in the planning of the work that they're undertaking, and you will hear more from them later this morning. Learning from these 5 boards will help the rest of us with the plans for change that need to be made. But we also know that the new model of care needs to be designed locally to fit each individual board's circumstances, the population it serves, the geography in which it works. One size will not fit all, but the underlying principle of delivering individualised care built around a woman, her family, her circumstances and her needs has to be at the centre of every midwife's practice. And we know it's not just women who benefit from a continuity of carer model. We now understand the impact of those early years on long-term health and well-being, that from as early as when the baby is developing in its mother's womb, the decisions and actions taken at that time can fundamentally change the future. So if we're to realise our national imperative around improving health and reducing inequalities, Scotland's reform can't just be about changing health and social care services to meet the growing needs of our population. It must also be about reducing that need in the first place, moving further towards prevention and interventions that can improve future physical and mental health and build capacity in individuals. And we know across government that that early investment and support pre-birth and through those early years is significant investment exceptionally well spent. Evidence also shows us that improving bonding and attachment between parents and children reduces risk in later life and improves educational attainment at school. That is why a key recommendation of the Best Start is that mothers and babies should be kept together as much as possible. Improved outcomes for most preterm and vulnerable neonates is one of our great successes in the past 20 years. We know that women and babies in neonatal care want to be with their child as much as possible, to be more involved in their care, and that they felt really anxious when separated. And staff have told us that we need to make it easier for them to keep families together. So we now know that we could minimize separation for families if we just did things differently. To support stepping down care so that babies can go home as soon as possible, we will develop a 7-day community neonatal outreach service. For those babies who need a little more support after birth, a neonatal transitional care model allows more mothers and babies to stay together as they get ready to go home. And for the small number who need more support, our neonatal service will be transformed to have family-centred care at its heart, with parents being partners in decision-making and providing as much care as practical for their babies, something I saw for myself when I visited the intensive neonatal unit at the Queen Elizabeth University Hospital, and had the opportunity to talk to those parents about how they felt being part of that unit and how their confidence and their relationship with their new baby was so significantly improved. And I also had the opportunity too to hear from the midwife staff there and the obstetricians about the challenges of those changes and the importance of listening to each other and working through where people had anxieties and concerns in order, always with that focus on what was best for baby and for mum. And the changes in Best Start fundamentally reshape neonatal care in Scotland, and we need to understand what those changes mean in practice. So that's why I've announced early implementer areas covering 4 neonatal units in Scotland to test the new model of neonatal care from end to end. These early implementers, NHS Ayrshire and Arran and NHS Greater Glasgow and Clyde in the west, and NHS Lothian and NHS Fife in the east, have started planning for implementation of the new model of neonatal care and implementation, and that will begin shortly. The early implementers will test out how this new model of care works in practice, devise the pathways and the protocols needed to ensure that the baby and family experiences of neonatal care are smooth, are understood, and are as well managed and coordinated as possible. The early implementers will also consider the implications and unintended consequences for staff and parents. That's important because we can have the best made, clinically led, experience-led plans, but until we start putting them into practice, there will always be consequences that we hadn't thought through, we didn't appreciate would happen. Recognizing at the outset that that will happen and being ready to deal with those and work our way through them will help us make sure that what is implemented as well as it can be. Learning from those early implementers, as I've said, help us, just as the early adopters help us improve what we are doing in a way that is consistent and make it easy to roll it out across the country. Another part of the Best Start that has already been implemented and will be relevant to early implementers' work is the establishment of the Neonatal Expenses Fund. The fund has been running for almost a year now and has helped hundreds of families across Scotland with travel costs and meal expenses, relieving some of the financial burden of having a baby in neonatal care and allowing them to spend valuable time with their new baby. Accommodation for these parents is already provided in the majority of neonatal units, but as part of the Best Start implementation, we want to make that provision standard across Scotland so that no matter where a baby is being cared for or however long they are in neonatal care, the family can have a place to stay where they feel comfortable and are close to their baby. The provision of facilities like accommodation for parents needs investment to deliver, and that is why it is right that we are investing £12 million over this year and next year to improve the implementation of Best Start. Some of the money has already been provided this year, and more is on the way in the next financial year to allow boards to invest in infrastructure, in training, and in equipment for staff to make the Best Start a reality. 8 boards have already received financial support to start work on implementing the Bliss Baby Charter to place families at the centre of a baby's care, and money will be available next year for the additional boards who haven't yet started this work. Last year saw the opening of 2 new alongside midwifery units, offering greater choice of place of birth for women, and a number of boards have already made great progress to either open or start planning to open a transitional care unit. The boards with transitional care are already seeing the benefits that early indications that this is delivering a 10% reduction in admissions to neonatal care in some areas. This is a clear benefit to families who get to stay together in those precious early days, and our investment will support all boards to offer these additional services to women and families. Another area of Best Start that has both care and financial benefits is the use of technology in maternity care. This is an area that has huge potential for maternity services to truly revolutionise how care is delivered. You will hear later this morning from NHS Highland and NHS Greater Glasgow and Clyde how they are using technology to hold virtual clinics between women in Argyll and consultants in Paisley. Benefits for pregnant women who need the input of an obstetrician to be able to speak to their consultant from either their local community hub or indeed from their own home, with their midwife beside them without the need of a 4-hour round trip to a hospital they are unfamiliar with. And for the consultant, who doesn't need to make those long journeys when the technology is so good that there is little difference between the woman being on a screen in front of her or on a chair beside her. And it allows the midwife to be part of that discussion, to hear what is said, to be an advocate for the woman if the woman wishes it, and be able to take forward the agreed plan of care. This isn't just a rural solution. This technology can be used across cities and towns in Scotland. The Best Start recommends the move to an electronic record for women, and in some areas this is already happening, with women able to access their own record from their phone. For any area in the health service to make maximum use of technology during care, then it is surely a service that cares for what is increasingly a tech-savvy generation of 16 to 45-year-olds is a good place to start and a good place to teach other parts of our health service how it can be done best. Now, as I mentioned earlier, I have been privileged to be able to visit some of the units. I've met some staff and women in recent visits to Forth Valley Royal, to Queen Elizabeth University Hospital, and to Cross House near my own constituency in Ayrshire. What struck me in all of those was the huge enthusiasm and energy that was being put into developing and implementing and delivering Best Start. Not unrealistic, not evangelical in the sense that it was all great and there were no problems, but a real enthusiasm for what could be achieved and for resolving practical difficulties as and when they might arise. But I was also struck by how the mums, the new mums, and indeed some of the new dads were talking about the relationship they had with their midwife, with the staff in those units and in the community, and how much it mattered to them, particularly if their child had been born very early, that they were part of that care. The confidence it gave them, the assurance it gave them, the connection it gave them in those vital early days when their plans for what it would have been like were knocked on the head a bit because the baby was born so early. So being able to hold on to some of what they had spent 9 months hoping for and being able to experience that just meant so very much to them. I really do believe that you are leading the way in our health service. This work is pioneering work, and being pioneers absolutely is sometimes difficult and it's sometimes challenging. And you will have times when you are worried about what is happening and what you are being asked to do. You worry because you care so much about the job you do. It is the other side of the caring that you give. You care about the women and their families and the baby, and you want the best for them. We want to hear from you about what is working well as you deliver the best start. But I also want to hear about the challenges, about your fears, and I want to hear what you think needs to be done that could be done better. It is important that this works for women and for families, but it is also important that it works for you during this time of change. So one of the areas that we have looked at to introduce is how do we offer additional expertise and experience and support in this transition period, particularly if you are new in your role or relatively new in your role as a midwife. Now, we know that there are many midwives and women working in this area with significant years of experience and expertise, many situations that you might come across that they have dealt with. And we also know that we don't want to lose that experience and expertise from those women who may then think that the only option for them is to retire. So for those who are planning to retire in the next few years, we're keen to hang on to you. We're keen to keep you so that you can continue to contribute to the area that you love so much. You have a wealth of knowledge, of skills, experience, and more importantly, you have confidence born of that in using those skills and abilities. And we don't want that to be lost. So that's why I asked the Chief Nursing Officer to deliver what is called the Professional Practice Advisors Pilot Project. The project will offer recently retired professionals the opportunity to work with colleagues in their specialties to help build confidence in role delivery and to support newly qualified nurses and midwives to reach their full potential. The project is currently in the planning stages, but we will start the pilot this year. It will work in practice with existing programs such as the clinical supervision for midwives and look to how it might support Best Start. So we are 2 years into our Best Start journey. You have already come a significant distance in implementation, and it will be important and inspiring, I hope, to hear about some of the progress that's been made throughout today. The positive changes for women are already being felt, and I want to thank you for all the work you've already put in. This is the right thing to do, and I believe it will deliver better care and better outcomes for women, babies and families. But more than that, I think the lessons from this change, how it has been devised, how it will be implemented, how you will help to shape it as it rolls out, are real important lessons that you are leading for how we transform other parts of our health service. I hope that you leave today feeling motivated, reassured and inspired. The evidence tells us that this is how we can offer babies the best start in life. And I very much look forward to working with you and to learning with you as we continue to make progress to make sure that we do give every child in Scotland the very best start. Thank you very much.